lot of people are getting sick and dying from this disease, such as my grandparents, so I think the best thing I could do was to get vaccinated. I think I chose to get vaccinated because I want to stay safe myself.
COVID has changed my life tremendously because before COVID, I was out a lot. I was hanging with my friends. I would do stuff that I love to do. I wanted to get vaccinated because I wanted to make sure people that were around me were protected.
It gives me that comfort knowing that I have something protecting me from a virus that's possibly really dangerous. The vaccine allows me to be able to do what I like and want to do normally without having to worry about the virus.
I decided to get vaccinated because if I could do anything to help get back to a normal life or get back to not wearing masks, and to get to see my family again, I'll do it.
The reason why I got vaccinated was to protect my loved ones. Getting vaccinated will allow me to do the things that I want to do, like playing basketball.
It's up to you, Missouri. Get vaccinated.
It's up to you, Missouri.
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 It's not just you as an individual that could potentially be affected, but even those around you, our community. That's how we were able to get rid of so many of these diseases that were killing people. The idea behind herd immunity. So if somebody don't fully complete their vaccination series, it's not just, you as an individual or, the mom or somebody making that decision, but it's also affecting the community. And so one decision can have a ripple effect for the entire community that you live in if we don't provide the herd immunity and also protect yourself. So I think that it's important to complete the entire vaccination series, no matter which one you start, to protect you as an individual, your family, your friends, and the community, so that these diseases that were killing people will not come back and flare up again in our communities.
Our next presenter is Dr. Kendra Holmes. Dr. Holmes is a St. Louis native and graduate of the University of Health Sciences and Pharmacy in St. Louis. She currently serves as Executive Vice President, Chief Operating Officer for Athena Healthcare. Athena Healthcare consists of 11 health centers which provide primary and preventative health services to underserved residents of St. Louis City and County. Dr. Holmes received the St. Louis College of Pharmacy Distinguished African American Alumni Award in 2013. She also serves as Secretary of the University of Health Sciences and Pharmacy in St. Louis and Board of Trustees and Trustee of Goldfarb School of Nursing at Barnes-Jewish College. Dr. Holmes is a member of the 2015 St. Louis Business Journal's 40 Under 40 class and received the St. Louis American Foundation's Excellence in Healthcare Award in 2016. Welcome, Dr. Holmes.
Good afternoon and welcome to St. Louis. Thank you for joining us for the Missouri Immunization Coalition Conference and discussion on equitable access to vaccination. My name is Dr. Kendra Holmes. I serve as Executive Vice President and Chief Operating Officer for Athena Healthcare. The discussion on equitable access to vaccination is vitally important and timely considering the COVID-19 pandemic. The photo that you're seeing on the screen is of an individual who was one of our first patients to receive the pediatric COVID-19 vaccine. Hopefully you can see the delight in his eyes at having received the vaccine. Once he received his Band-Aid, he said, "Now I feel like Superman." My hope and our collective hope is to have that shared confidence in vaccination as this young man. And vaccination is definitely important. The CDC lists the top public health achievements of all times. They include items such as motor vehicle safety, safer workplaces, control of infectious diseases, decline in coronary artery disease and stroke, of course, healthier moms and babies, but by far, the most exciting and important public health achievement is vaccination. The CDC also has a vaccination timeline, which includes all of the great achievements of vaccination throughout history. It begins about 400 BC with Hippocrates describing conditions such as mumps, diphtheria, and jaundice. Then fast forwards to about the 1100s with the variolation technique, which was developed in areas such as Africa, Turkey, China, and Europe, and really was the process in which individuals were inoculated with the smallpox vaccine. Of course, in 1798, we're all familiar with Edward Jenner and the development of the smallpox vaccine, and being considered the father of immunology. A question that we might consider is, how did the concept of variolation get to the colonies? Well, unfortunately, as the lack of vaccine equity often mirrors equity in scientific discoveries for individuals of color, there are some individuals who are definitely absent from history. Onesimus is an individual that many of you may not be aware of. This was an individual who was actually a profound and significant impact on the development of the smallpox vaccine. Onesimus is actually the Greek word for useful, and he did prove to be quite useful. He was an enslaved man from West Africa. He was actually purchased by a Puritan minister by the name of Cotton Mather in Boston. During this time in 1721, there was a tremendous smallpox outbreak in Boston, which tore through the colonies, killing both the colonists and the Native Americans. Onesimus was actually the first individual to share with Mather the West African practice of variolation. We know this because Mather kept a very detailed diary of all of the information that Onesimus provided, and he actually confirmed this information with other West African slaves in Boston. This information was shared with the local physician who began the process of variolation, inoculating Bostonians against smallpox. Prior to the inoculation, there were 1 in 7 deaths due to smallpox. After this process, it improved to 1 in 40, so definitely a success. This information provided by Onesimus was foundational to the development of Jenner's vaccine. So why the history lesson, you may ask? Well, building trust in communities of color is something that we struggle with when discussing vaccine equity. So early in the pandemic, the NAACP did a survey which asked individuals about their trust in COVID vaccines and their possibility of receiving the vaccine. Well, only about 14% of Black surveys said that they thought the vaccine was safe, and only around 18% said that they would definitely get vaccinated. So why is this important? Well, perhaps if these individuals knew about individuals such as Onesimus, a West African slave who contributed to the development of the vaccine. If these individuals knew about Dr. Corbett, who was a Black woman and viral immunologist who was instrumental in the development of the Moderna vaccine, perhaps they would be more likely to trust vaccines. Academic institutions must provide accurate accounts of the contributions of people of color in science and health if we are able to get beyond Tuskegee. But let's talk about the successes of vaccines. Vaccines are successful. They're cost-effective at prevention of disease. The World Health Organization estimates that immunization currently prevents 2 to 3 million deaths every year. Let's talk about the eradication of smallpox, which occurred in 1980. This is often considered the biggest achievement in international public health. A lesser known is the eradication of rinderpest, also known as cattle plague, which resulted in tremendous poverty and famine. Vaccines currently prevent more than 20 life-threatening diseases. We even have a vaccine to prevent cancer. With all of these successes, It seems as a no-brainer that individuals would want and seek vaccines, yet we struggle with vaccine inequities in underserved communities and throughout the world. With those successes, often we must discuss some failures. Vaccination coverage has definitely plateaued in recent years and even dropped for the first time in a decade in 2020, of course, which correlates with the COVID-19 pandemic. An estimated 23 million children under the age of 1 did not receive their basic vaccines. This is the highest since 2009. In 2020, the number of completely vaccinated children increased. Unvaccinated children increased by 3.4 million. 1.6 million more girls are not fully protected against the HPV virus. Global coverage with the HPV virus is now estimated at only 13%. And related to COVID-19, in nearly half of US states, Black and Hispanics COVID-19 vaccination significantly lags behind whites at about 10 percentage points below. And perhaps vaccination is at the top front of a lot of our strategies throughout our health centers. We have struggled to get individuals to be vaccinated and also to be tested as well. There's been, throughout the years, much opposition to vaccines. I would argue that the opposition to COVID-19 vaccine is one that we have never seen before. We saw at the beginning of the pandemic healthcare workers nurses, doctors, physicians, pharmacists opposed to the vaccine mandates. We see the opposition in the political forefront with politicians, religious opposition, human rights activists, even parents in schools. The opposition to the COVID-19 vaccine is seen throughout all demographics. There is opposition in rural areas, urban areas, Black areas, and white areas. With that opposition, we see that the data definitely shows that there are individuals who are not being vaccinated. So as of April 2022, the data shows that Asians have significantly higher vaccination rates for COVID-19 compared to the Black and Hispanic population. Correlating very closely to vaccination, of course, is infection, hospitalization, and death rates. And unfortunately, as we know, the Black and brown communities have been disproportionately impacted by COVID-19. We see that in the rate of hospitalizations and deaths for Black, Hispanic, and American Indian or Alaska Native communities. One item that no one likes to discuss is child mortality, but it's something that we definitely have to discuss related to COVID-19 and child mortality, and also related to vaccinations. Again, we see that significant disparity in the child mortality for Asian Pacific Islander individuals and also for Blacks and Hispanics. While COVID-19 has definitely put a strain on all of us throughout healthcare, I personally feel like I've been fighting for 20 years just to get individuals to take the flu vaccine. Influenza vaccination rates among adults and children has stark disparities. We see that, again, Blacks and Hispanics have lower vaccination rates compared to the white and Asian community. Also with children, we see also disparities with the Black, Hispanic, and communities of Asian descent. Flu vaccination coverage for children has definitely been impacted by the pandemic. Actually, all individuals and racial groups have been impacted as far as the flu vaccination rates. Correlating to the lower rates of immunization for flu vaccine, we also see an increase in hospitalization. Again, with non-Hispanic Blacks and non-Hispanic American Indians having significantly higher hospitalization rates related to the flu. I mentioned previously that we have a vaccine to prevent cancer. The human papillomavirus is that vaccine. Nearly 42 million people are currently infected with HPV in the United States. In the US, nearly 36,000 people are estimated to be affected by a cancer attributed to HPV. The good news is that HPV vaccine has the potential to prevent more than 90% of those cancers. Although this is a vaccine that can prevent cancer, we still see stark disparities in vaccination rates. In 2019, only about half of adolescents aged 13 to 17 were up to date with their HPV vaccinations. Asian and Hispanic populations and adolescents with Medicaid coverage were far more likely to be vaccinated by an HPV vaccine compared to individuals without insurance. As far as boys, we see a stark disparity with the rates related to boys versus girls. HPV vaccination rates among teen boys are significantly lower than girls, 52% compared to 57%. Some states actually require the HPV vaccine for students to enter the 6th grade, but they also allow for parents to opt out for specific medical, moral, or religious oppositions. We also see those disparities again related to states. So HPV vaccination rates by state definitely vary. We see rates of about 31% in Mississippi compared to 79% in Rhode Island. Marketing of the original HPV vaccination definitely had some issues. There was more of a focus on girls and cervical cancer, which caused a lot of boys not to be vaccinated. There was definitely less utilization in boys and a limited focus on the LGBTQ+ community. Also, cervical cancer really was the pivot or the point that most of the marketing really focused on. And it did not include information about the other cancers, such as throat cancer, mouth or head and neck cancers, and also genital warts, which was prevented by the HPV vaccine. And of course, we have to discuss the stigma. Many parents felt that they did not want to give their children a vaccine that might, in their mind, increase risky sexual behavior. Well, a recent study found that state laws regarding HPV vaccinations and education are not associated with any changes in adolescent sexual behaviors. The percentage of individuals who have received one or more doses of human papillomavirus vaccine definitely shows some disparities. We see again that those individuals who have the highest rates of vaccination for HPV are non-Hispanic white women. A point is the stark disparity between women and men, where men have significantly lower vaccination rates compared to women. When we look at the risk, we see that the risk is actually higher for men, although they are not being vaccinated. So in particular, non-Hispanic Black men have the highest risk for HPV, and these are also the individuals who have the lowest vaccination rates. So we've talked a lot about the numbers, and the disparities exist. Disparities exist as far as gender, race and ethnicity, socioeconomic factors such as poverty, even insurance coverage. We see disparities with immunization related to their state, people's religious preference, political views, and of course, access. So what are some key strategies that can be implemented to increase equity for immunization? In the photo, you'll see two of my immunization champions. They have on their shirts that say, "Be wise, immunize." I can't stress enough the importance of education when developing strategies for equitable distribution of vaccines. Culturally competent education is definitely needed, but not only for our patients, for our parents, our providers, the staff, and the community. And we really need to resist the temptation of being judgmental. I myself at times have said, why would a mom not get their child vaccinated? Why would a mom not want their child to be protected against HPV or other diseases? Well, we need to really resist the temptation of confusing poverty and lack of education with negligence and neglect, because there definitely is a difference. So again, that focusing on educating and providing culturally competent education is key. And dealing with different populations, it's going to look different. The information that I may provide to one of my Afghan patients may be different than what I provide to one of my Asian patients when I'm trying to discuss the HPV vaccine or a COVID vaccine. So providing culturally competent training to your staff is absolutely key. Creating a culture of immunization begins at the top with leadership. Leadership needs to understand the importance of immunization, not just to the bottom line or meeting our quality goals, but the impact on quality of life to the entire community. That means directing resources, to your immunization efforts. That means that individuals, sometimes overtime is needed for community events, but leadership has to be on board with immunization being a strategic priority. Next is data is justice. You have to be able to identify the disparities in your communities, in your health centers, in order to make an impact on immunization disparities. So what populations in your health centers or in your communities are lacking with their COVID vaccinations? Which populations are lacking with HPV vaccinations? The data that you receive must be tracked, reported, and then initiatives developed to actually make an impact on those initiatives. For example, we noticed that our medication-assisted treatment patients, those are our substance use disorder patients, were all lacking in their flu vaccines. Those individuals often aren't necessarily linked to our medical plans or our medical services, so we made it possible for those people to be vaccinated in the medication-assisted treatment suites. Because again, access points are very important. I say this to my team all the time. If a patient gets back to the exam room and the provider is trying to explain to them why a COVID-19 vaccine is important, we failed that patient. The education on vaccination should occur on the front end prior to that patient getting in the exam room. That should occur with our nursing staff, our navigation staff, and our community health workers. Access points beyond the exam room are key. If you have information to be provided throughout the pharmacy and our behavioral health departments, that is where the education can also be given to patients. We have it where our behavioral health services are integrated with our medical services. So if individuals are not going to our medical services, they can be vaccinated in the behavioral health department. Very similar to our dental and urgent care services. We run reports regularly for the patients that are in our dental and urgent care to determine where their vaccination gaps are, and we provide those services on site. Again, this information should occur prior to getting into the exam room. So huddles are extremely important. Your nursing team should be looking at the patients prior to their arrival and determining what are their gaps in immunization. Pre-visit planning and population health are important to decreasing these disparities. Partnership. Access is still an issue for many underserved individuals as far as vaccination. One area that we struggle with is transportation. We were very fortunate to be able to partner with First Student on a vaccine shuttle. This shuttle provided access to individuals in underserved communities to our health centers for not only for COVID-19 vaccines, but for adult vaccines and pediatric vaccines as well. I urge you to look at your partnerships and see how you can identify barriers to vaccination and work with partners to help come up with strategies. Outreach. So again, the outreach to communities is not just in your internal health centers. You have to outreach to the surrounding communities who you may not be serving in your health centers. We have a large outreach team that focuses on not just those individuals in our direct communities, but foreign-born populations, the LGBTQ population, any individuals and communities who are in need of vaccination. I would urge you to partner with an institution that is trusted in those communities. A trusted institution that we partner with frequently is the International Institute. Through the International Institute, we're able to, again, connect with communities that we were previously not connected with. We have interpreter services available and resources if other resources are needed for this community. School-based health centers are an excellent means for impacting immunization disparities. We have 3 school-based health centers, and in the photo you're seeing now, I'm actually talking to some of the male students about the HPV vaccine and the importance to that vaccine to them as males for prevention of cancer. School-based health centers provide an excellent access point for individuals who may not have access to a clinic or a health center. We provide vaccinations in-house. Students can come right after class and receive whatever vaccination education or needs that they have. I mentioned previously about leadership and the importance of leadership towards coming towards equity for immunization. We are very fortunate at Phinia Healthcare to have a dynamic chief medical officer who is an OBGYN and is as passionate about vaccination as I am. In the other photo, you see me receiving my first COVID-19 vaccine. And I can't stress again the importance of leading by example. We did have individuals, staff members who were reluctant to receive the COVID-19 vaccine. And the method that we took is really, again, what I spoke about earlier is education. We had lunch and learns where we discussed the importance of the COVID-19 vaccine. We allowed any staff members to voice their concerns or ask any questions about any safety issues that they felt about COVID-19 vaccination. And we're very happy that our vaccination rates are over 99%. So again, leadership, leading by example, setting the example and being present in the community is definitely important. Community, I've spoken about community several times. Pictured here is our Crushing COVID vaccination team. Our community team provides probably about 5 community events a week where we go to various organizations throughout the community and provide not only vaccinations, but education. And I want to stress again the importance of being present in community. You can't just show up with your COVID-19 vaccine without first interacting with that community and building trust. And this is what our teams have done throughout the St. Louis region, be that in churches, community centers, or organizations or schools. We work to build that trust in community and then discuss vaccination options. This is our lead vaccination coordinator, Juanita, and if you can see her shirt, it says, "If you are reading this shirt, it's not too late to vaccinate." And to this point, I would urge us all to not be judgmental related to vaccination. Some individuals have very justifiable reasons why they are reluctant to be vaccinated against COVID-19 or the flu vaccine or any vaccine in particular. It's very important to acknowledge that some communities have had harm from the medical community and are distrustful of the medical community in general. We have to work to regain that trust in those communities. And it starts by number 1, not being judgmental and being present. We have to start with building the trust if we're able ever to decrease the disparities with vaccination equity.